As ever, we invite people to join our panels and speak based on their expertise and experience. Their remarks do not reflect the views of Harvard University. I'd also like to acknowledge and thank our co-sponsors, the Center for Middle Eastern Studies, the Religion, Conflict, and Peace Initiative at the Harvard Divinity School, and the Carr Center for Human Rights Policy at the Harvard Kennedy School. I'm extremely grateful to the Palestine Program for Health and Human Rights here at FXB for working quickly to pull this webinar together along with the dedicated staff here at FXB. But before I introduce the panel, I'd like to make a few remarks. In July of 2022, I was the New York State Health Commissioner when a young adult with paralysis was diagnosed with polio. Wild poliovirus was eliminated from the United States in 1979. That's 45 years ago. But polio did continue to be diagnosed in people who'd been infected outside of the United States and come back and become ill. But this young person had been infected by a circulating vaccine-derived poliovirus that was acquired in the United States, specifically in New York State, and not from travel. The virus had been introduced into human populations elsewhere because it arose from an oral polio vaccine that is no longer in use in the United States. This vaccine, as you'll hear from our panelists, I'm sure, uses a live attenuated virus that can rarely, fortunately, revert to a virus that can cause paralysis. But that there was circulating vaccine-derived poliovirus in the United States and in New York State was a source of a tremendous shock. Because of this case, the United States joined the list of several dozen countries that have circulating vaccine-derived poliovirus. And I want to make clear that this virus is not less, well, you'll hear from others, but this causes polio just like wild virus, paralytic polio. But in contrast, I don't think anyone was very surprised when circulating virus-derived polio type 2 was found in wastewater samples in Gaza in July of this year. An alarm at that time was quickly expressed and anticipated of paralytic polio cases following. Tragically, this then happened. And to talk about this today, I am going to introduce our panelists. I will introduce them one at a time and then invite them to speak for 10 or 15 minutes. I want to let everybody watching know that there's a QA function at the bottom of the screen, and you can use this function to ask your questions as we go along. You don't have to wait to the end to ask your questions. So I'm going to start with Dr. Amir Mohareb, who will start out by giving us an overview of polio and the conditions in Gaza, that an area that had been polio-free for 25 years. Dr. Mohareb is an infectious disease doctor at the Massachusetts General Hospital and an assistant professor at the Harvard Medical School. He directs a research program there on humanitarian action, global migration, and infectious diseases. And his research focus has been on HIV, viral hepatitis, and tropical diseases, particularly among people who are facing forced displacement. But today, he'll be talking with us about polio. So over to you, Dr. Mohareb.
Thank you, Dr. Bassett, and I'm grateful for the organizers of this conference, the other speakers, and all of the participants. And I think maybe to frame the conversation, I would like to start a little bit by giving an overview of what polio is and how we vaccinate against polio. As many people in the audience surely know, polio is a virus that in many people can infect the spinal cord. That's the most feared complication is acute flaccid paralysis, or essentially infection of the spinal cord that causes a paralysis or inability for a muscle to function. At its most severe form, it can cause a problem with breathing, affecting the muscles of the diaphragm, which control the lungs and help us breathe. There's been a campaign to eradicate polio since the 1980s, and that campaign has been, um, by all accounts, incredibly successful. Whereas we had, hundreds of thousands and tens of thousands of cases, the spread of vaccination throughout every country in the world has basically made polio much, much rarer, has cut it down by more than 99% over the first, 10, 20 years of that campaign. There are two types of polio vaccines. One is an inactivated vaccine that is an intramuscular shot. This vaccine is very effective. It's safe. Um, but it is not as practical to be used in an outbreak setting, particularly in low resource environments. But thankfully, we have another vaccine, which is the oral polio vaccine, which is the one that's used in the majority of low-income countries around the world. That is a live attenuated vaccine, meaning it uses a weak form of the actual virus to induce immunity. That vaccine is also very safe and effective. It is also very affordable and easy to distribute in a mass campaign. It also has the advantage that it probably induces more gastrointestinal immunity to poliovirus, and that's significant because individuals who get vaccinated may shed some of that vaccine in their stool and actually help immunize some of their household contacts. But that characteristic has a very rare downside, which is when the virus, the weakened form of the virus that's in the oral polio vaccine, gets shed in the stool. After several generations of getting transmitted, if it's being transmitted among people who have no immunity, it can rarely form a genetic mutation that reverts it back to something that looks like the wild type vaccine. What Dr. Bassett said in the introduction is absolutely true. That form of infection, once it's reverted back to the wild type characteristic, is basically indistinguishable clinically from wild type polio disease. And so since around 2016 or 2017, we've actually had more cases of that kind of infection, which is what we all call vaccine-derived poliovirus. Again, to be clear, even though it's called vaccine-derived poliovirus, this is not the vaccine causing infection. It's the vaccine having this effect where if everyone is under-immunized around someone who's gotten vaccinated, then that strain can revert to become a virulent form. We get more cases of that than actual wild type polio. Wild type polio is essentially only found in Afghanistan and Pakistan, whereas many countries in sub-Saharan Africa have seen outbreaks of vaccine-derived polio. And there was an outbreak of vaccine-derived polio virus a couple of years ago in Egypt. There's been one also in Syria, in Yemen, in the context of the war there. And so I'll kind of wrap up this little bit just to say it was really predictable that this was bound to happen in Gaza, and health professionals were predicting this 6 or 7 months ago, even longer, when we all saw before our eyes the healthcare system being systematically destroyed, hospitals being attacked as targets, and political and even health professionals around the world legitimizing those attacks in many ways. We saw this as we've seen doctors and healthcare workers get assassinated or abducted and kidnapped in Gaza by the Israeli military. And in this entire campaign, which of course, ICJ called a plausible case of genocide. And so when we've seen that, and we've seen water and sewage kind of rage through the Gaza Strip, and displaced population live under those conditions, the expectation is that these infectious diseases, not just polio, would ravage the population. Even though poliovirus was found in the wastewater, it was just a matter of time for it to be diagnosed clinically. And we'll speak, I'm sure, a little bit about how well vaccinated the population in Gaza was. In 2022, they more than 99% of them were vaccinated against polio, but under vaccinated against this specific strain. And then, of course, since 2023, there's essentially been no vaccine campaign available because of the war and the humanitarian crisis there. So maybe the last thing I'll say, kind of before moving on, is a diagnosis of symptomatic polio is often seen as the tip of the iceberg. There could be estimates of for every case that's diagnosed, 100 or 200 silent polio infections could be in the background. That's what's been estimated in other outbreaks. I would even venture to guess that the ratio is more dire here in Gaza, where, like I said, there is a lack of a functional healthcare system there, a lack of access to get clinicians to even diagnose these cases. And then add on top of that, several other intervening or competing risks of disease, like other infections, trauma, malnutrition, and so on. So I'll wrap it up there, and I'm looking forward to discussing more about how really this outbreak is a consequence of two things. One is the shortcomings of the global eradication campaign, which by all accounts were successful, but really missed the mark in places like Gaza and before it, Yemen and Syria and other places that have this political determinants of infectious disease spread, which is caused by war and poverty, underdevelopment, and so on. So thank you, Dr. Bassett.
Thanks very much for that really succinct and useful summary. I'm going to turn now to Sam Rose, who's actually just recently returned from Gaza, where he was there during the polio vaccination. Maybe you can say something about the cases that were diagnosed that sort of led to the political consensus to at least allow pauses for children to be vaccinated. So he will be talking about this what I can only describe as heroic effort to vaccinate hundreds of thousands of children under the age of 10 against the type 2, which was a type of vaccine-derived virus that was identified in the wastewater, and I believe in the child who was diagnosed with paralytic disease. Sam is a senior deputy director of the United Nations Relief and Works Agency and Affairs, UNRWA, in Gaza. And as I've mentioned, he's been in Gaza for the last weeks of the vaccination campaign. The floor is yours, Sam.
Thanks, Mary, and thanks for having me on, and to the organizers for putting this program together. Very happy to speak to you today. I am normally based in Gaza, as you said, but I'm in the UK today, just on a break. I've been in Gaza for much of the last much of 2024 anyway. But look, as you said, maybe start, Mary, with where you ended. As Amir said, there were traces of polio that were detected in the wastewater system in July, a direct result of the conflict in terms of what that's meant for the decimation of the healthcare sector, the decimation of the solid waste management and sewage infrastructure as well, and the fact that so many people, 90% of the population, or 1.9 million people, have been on the move since October, and the vast majority of them remain displaced. So the virus was detected in wastewater, and then in August, 3 suspected cases, of which one was finally confirmed, a 10-month-old boy suffering from partial paralysis. And as a result of that, a decision was taken, and the Global Polio Eradication Initiative was activated with a target of vaccinating all children under 10 in Gaza, and that was a target of 640,000 children across the Gaza Strip. The first round the virus has to be administered in two rounds. The first round was completed a couple of weeks ago, and about 560,000 children were vaccinated in the first round. Now, what experts have said at the outset of the campaign was for it to be successful, 90% of the target population has to be reached. Now, this figure of 560,000 is slightly below that 90% target, but nevertheless, and I'll come back to this in a bit, that the campaign has been deemed a success in terms of the share of the under 10s reached. Now, the decision was taken to have that 10 years as a cutoff because it's been for the past 10 years that children in Gaza have not been vaccinated against this type of polio. It was taken out of the vaccines about 10 years ago. So there is a bit of a gap. As Amir said, vaccination coverage in Gaza, the EPI program was universal, above 99% until 2023. Even since the war, lots of vaccinations have continued, but the coverage has fallen way beyond, or way below rather, that 90% ceiling, as has already been mentioned, as a result of the decimation of the healthcare sector, but also of the difficulty faced by populations in vaccinating their children when they've got more immediate concerns and or are constantly on the move. But look, the campaign was a success because of the planning that went into it, all the way up from the technical leadership from WHO, right the way down to the skilled professionals, the skilled health professionals on the ground. That includes the Ministry of Health, doctors, vaccinators, the registry people, the social mobilizers from UNRWA and UNICEF, and also over 1,000 UNRWA staff who were involved in the campaign itself. I mean, UNRWA, along with the Ministry of Health, we run essentially the primary healthcare system in Gaza. So it's in these entities where the expertise lay, the professionalism lay, that meant the campaign was a success, and important to remember that and pay tribute to those who were directly involved. But look, everything about it was extremely complicated. And with multiple layers of complexity. The complexity began at the planning stage. Bringing things into Gaza has always been complicated. That complexity has got exponentially greater since the 7th of October. Then moving things around Gaza are also very difficult due to the lack of fuel, the damage to infrastructure and roads, poor communications, ongoing fighting and poor logistics, etc. So there were high-level political negotiations that lasted for several weeks to agree for the campaign to go ahead. Now, the nature of the conflict meant that it had to be administered in 3 separate phases. Gaza, since the middle of October, has been separated into 2. A checkpoint has been established separating Gaza City and northern Gaza from the rest of Gaza, but a decision was taken, or it was insisted rather, by the Israeli authorities that the campaign take place in 3 distinct phases that would run in sequence. So we started in the middle of the Gaza Strip. The campaign ran for 4 days there. Then we moved to the southern part of the Gaza Strip for another 4 days and ended in the northern part of the Gaza Strip above the checkpoint that I referred to. Now, that wasn't the preferred approach by any means. We'd have rather, ideally, we'd have conducted the campaign across the entire Gaza Strip in one go. But even with the reality of the conflict, we pushed hard to have the campaign administered in 2 separate chunks. So taking the middle and the southern part of Gaza together and then moving to the north. But that simply wasn't possible. And we anticipate that we'll continue in these 3 different phases when we move to the second round in a few weeks. Now, pauses in fighting were agreed each day that the campaign was underway in these areas. So between the 1st and the 4th of September in the middle area, and then subsequently in the south, between 6 a.m. and 2 p.m. each day while the campaign was underway. And that was essentially the operating hours of the health clinics and the health points. Across Gaza, the vaccines were administered in a number of ways, quite often at fixed health points, also at temporary health centers that have been set up, and health points established in the dozens upon dozens of UNRWA shelters that are UNRWA schools rather, that are functioning as shelters, functioned as shelters since the 7th of October last year, and are providing shelter for hundreds of thousands of people, both within the shelter itself, but also in the vicinity of those shelters. There are people who are registered and who rely on UNRWA for services. So those pauses were agreed in each of the areas, but unfortunately they didn't cover the entire geographical area of the three different zones of the Gaza Strip. So if we take the middle area of Gaza where the campaign started, it was really in the western parts only where the pause in fighting was agreed, inside what were referred to as polygons. Outside of those polygons, the fighting continued. There was no agreement by Israel not to issue evacuation orders. And whilst the majority of the population and the majority of the healthcare facilities and health points are located inside these polygons, there were large proportions, or significant minorities rather, of people who were outside of those polygons. So if we look at southern Gaza, about 30% of the total target population was located outside of the polygon. That made it very difficult for us to coordinate movements of vaccines into these areas. It also made it more difficult for our staff to work and move around, and equally importantly for the parents and their children to bring their children to the vaccination centers. And then I guess there were specific complexities around the campaign in northern Gaza. We started in the middle because that was, relatively speaking, the easiest to manage in terms of the number of people there, the relative the extent of the destruction and the displacement. But the north of Gaza has been cut off since the 13th of October. We continue to run health points and health clinics up there, but the area has essentially been isolated. So it was always going to be much more complicated in northern Gaza, given that, but also the nature of the conflict there, which has been much more fierce and much more violent. And look, so it turned out we had hoped to bring some of our experts, our health managers, up from southern Gaza to northern Gaza to essentially apply the lessons and the practices that they'd learned from the two phases in the middle area and the south, to bring them to northern Gaza and assist with the administration of the campaign in northern Gaza. And with that in mind, a convoy of, I think, 12 United Nations staff, a couple of INGO staff, did try and move north on, I believe, the 10th or the 9th of September, moving through that checkpoint. The staff were stopped at the checkpoint, staff who had been screened, staff who had passed through that checkpoint several times since the 7th of October, and they were subject to a fairly horrific and violent assaults involving gunfire, involving bulldozers and tanks that essentially pushed the armored vehicles that were in the convoy together. And two of the staff, two national UNRWA staff, well, one national UNRWA staff, one former national UNRWA staff were threatened with interrogation and detention. They were kept there for several hours, and in the end, the convoy had to turn round. So just at a time whilst this was going on, the Israeli army putting out media releases to say that a polio convoy being led by the United Nations had been infiltrated by terrorists. So it was a very difficult moment, but essentially whilst the convoy had to turn round, we were able to administer the campaign in the north. It perhaps wasn't as successful or as effective as it might have been, but it passed off, and we're hopeful that it will run successfully again in a few weeks. And now, look, overall, the campaign was very well organized. Difficulties in terms of the cold chain, in terms of moving the vaccine around to tens and tens of different locations at short notice, and essentially running against the clock, given the short time frame in which the pauses had been agreed. But for the first time in several months, we saw families out on the streets, parents with their young children. For many, it was the first time that they'd been out of the house with their children since the start of the war, queuing in an orderly manner, children very well dressed, and I wouldn't say looking forward to having the vaccine, but certainly the level of acceptance and understanding was very, very high. And as I mentioned at the start, we were able to pull this off because of the professionalism of the different actors involved, from the World Health Organization, UNICEF, UNRWA, my organization, but also the Ministry of Health and the other INGOs that were and NGOs that were involved. It was a massive endeavor. Over 2,500 personnel involved in over 1,000 teams, registering the children, administering the vaccine, and also raising awareness amongst the population through mobilizers. We were able to mobilize extremely quickly, partly using the existing staff that exist within these organizations, but also using the temporary employment and emergency employment instruments that UNRWA, as a large-scale humanitarian actor in Gaza, has at its disposal. The types of instruments that we have to hire quickly like this, we have thousands, hundreds upon hundreds of trained medics on our books already. It wouldn't have been possible for any other UN organization to have achieved that. And just quickly on the post-vaccine assessment, going back to that initial target, a technical assessment was completed a couple of days ago involving a sample of about 11,500 children. What they found was that of those children, 97% of them had received the vaccine, and that's what's led us to the conclusion that whilst we were below the 90% target that was initially set, we feel that the campaign was a success, and that if anything, that 640,000 target was an overestimation. It was based initially on the census conducted by the Palestinian Central Bureau of Statistics in 2017. So it's already quite an old estimate when it comes to population projections. Coupled with that, we've had the disruptions created not only by this war in terms of killing, death, and out-migration, but also the disruption of the COVID pandemic of a few years ago, which has meant that, we believe that initial target of 640,000 was something of an overestimate. It also made it more difficult to set targets for these smaller geographical areas because we simply didn't know precisely how many people were in those areas, given the extent of the movement over the last 11 months. And actually, we hit a very high target in the middle area on the first day of the campaign. And as a result of that, Israel was minded at one point to reduce the number of days that we needed to hit our target. We were able to negotiate them down from this, but it just gives a sense of the type of the environment in which we're operating. And as well as perhaps the target in the middle area having been overestimated, what we also saw was lots of parents from the south bringing their children to some of the clinics in the middle area, just out of a desire to get their children vaccinated as quickly as possible. And the second phase will get underway in 3 to 4 weeks. We're still waiting the precise start date. There's a number of Israeli high holidays that are coming up, and that just complicates efforts to bring the vaccine in, to bring people in, to bring the fuel in across the borders. But we have commitments that second phase will go ahead. We're just waiting to fine tune the date. But look, I mean, there's been a lot of focus on polio, and I think it was a glimmer of light in a desperate situation. But the reality is that the conditions in which a reemergence of polio were able to take place, those conditions persist. The children who have been vaccinated have gone back to the same conditions in which they were living. So if they're not going to, contract polio, they're still highly likely to contract another infectious disease over the coming weeks. And just last week, one of the schools in which the polio campaign was being administered by UNRWA was subject to a military operation. Up to 20 people died in that military operation, including children and including tragically 6 UNRWA staff members. So look, until the conflict comes to an end, as we've said on many occasions since the start, these types of issues will continue to arise. This week it's polio, but next week and the week after it may well be something else. And with that, Mary, I'll hand back to you. Thank you.
Thanks very much, Sam Rose. That was, definitely you've heard about a very heroic effort under conditions that have not been remedied. We have as the last member of our panel, Guy Shalev, who is the Executive Director of Physicians for Human Rights Israel and a research fellow at the Minerva Center for the Rule of Law Under Extreme Conditions. He's a medical and political anthropologist who specializes in the intersection of medical professionalism, ethno-national politics, and bioethics in Israel, Palestine. He received his PhD from the University of North Carolina, Chapel Hill. He's going to be talking, taking us broader and talking about the political context of the Israeli occupation and military actions in Gaza, the impact of the occupation on the Israeli medical community in general, and in particular regarding the diagnosis of polio in Gaza. Guy, thanks very much for joining us. I'm not sure where you're joining us from, but over to you. The floor is yours.
Thank you, Dr. Bassett, and thank you for organizing this important webinar. I'm in Tel Aviv right now, speaking to you from the Valley of the Beast. So I'll continue from where Mr. Rose stopped his presentation, and that is the context in which we're talking about these campaigns, these very impressive international campaigns that need also to deal with a lot of challenges that the Israeli government is putting in place in order for these campaigns to be successful. And Dr. Muharrab talked about the destruction of Gaza as maybe the important context that we see for this outbreak, with the destruction of the healthcare system, more than 1,000 healthcare workers who died during this attack, destruction of the water and sanitation infrastructure. This is, of course, a context that we need to put in mind when we're thinking about the subject of today, the poliovirus in Gaza. And this is, of course, the result of an attack on the Gazan healthcare system in a scale that, there's research that shows that the rate of attacks on healthcare facilities in Gaza is higher than any other conflict globally in recent years. And that is, of course, how we got to this point. In the introduction, Dr. Bassett, you said that no one is really surprised that poliovirus was discovered in Gaza in this context, but also you mentioned that the Gaza Strip was polio-free for 25 years. And I think we need to remember that when we speak about this current situation that we are in. The Gaza Strip is under occupation since 1967, for almost 6 decades, with a lot of its population refugees from 1948. And still under really horrible conditions, the Gazan healthcare system was able to operate under blockade, provide healthcare for the people of Gaza with a lot of, basically every part of Gazan society part of this public system. And that is what made Gaza, I guess, polio-free for so many years, in spite of these unimaginable difficulties. And for us in Physicians for Human Rights Israel, we have been working with the Gazan healthcare community since 1988. and more kind of systematically since the blockade started. We dispatched more than 100 delegations until October 7. Actually, our next delegation was supposed to leave on October 12th, and of course was cancelled. During this time, we met and worked with very professional and dedicated healthcare workers in the Gaza healthcare system. And I'm mentioning this just to say that we didn't have to be in this point where Gaza is facing this humanitarian crisis that is viewed as a humanitarian crisis that should be addressed by international organizations as we see it now, especially mentioning that it is Israel's responsibility for the population of Gaza as a population under occupation. It's Israel's responsibility for the health of the population of Gaza and the West Bank. Article 56 of the Fourth Geneva Convention specifically provides that an occupier has a duty, right, to ensure the adoption and application of the prophylactic and preventive measures necessary to combat the spread of contagious diseases and epidemics. So this duty includes providing support for the purchase and distribution of vaccines. So it is actually Israel's responsibility to make sure that Gazan children are safe and are not exposed to poliovirus. And looking at the recent advisory opinion by the International Court of Justice, we should keep in mind that all these humanitarian efforts should not absolve Israel of its fundamental responsibility to safeguard the health of Palestinians in Gaza. And this should, I think, be viewed against a backdrop of many years of Israel's medical apartheid of Palestinians. Speaking about vaccines, we can take the example of the COVID-19 pandemic, and see that, for example, we at PHRI appealed to the High Court of Justice in Israel in March 2021 to force the Israeli government to provide COVID-19 vaccinations in the West Bank and Gaza because of Israel's responsibility for their health. At that time, almost 6 million of Israel's citizens were already vaccinated, with only a few thousands vaccinated in the West Bank and Gaza. Israel did vaccinate 100,000 Palestinian workers in Israel and Israeli settlements. So looking into these vaccination campaigns, we can see that it has a history of apartheid that needs to be acknowledged. As Mr. Rose said, we need to acknowledge that as much as these conditions that cause this outbreak of poliovirus and also cause many other healthcare issues are related to this, of course, extreme conditions of the attack on Gaza, but also to the extreme conditions of Gaza for decades. So even if we're getting into the point that we are all hoping for of a ceasefire and an end to the actual aggressive military attack on Gaza, still we need to acknowledge that all these conditions, that social determinants of health and infrastructure that is in place in Gaza is still something that will need to concern us for many years going forward. And one last point that I want to refer to is the Israeli medical community. We are part of the Israeli medical community. We're an organization that is based in Israel. And we looking at Israel's medical community reaction to the finding poliovirus in Gaza is telling a lot about that community's moral failure to acknowledge that the results of the Israeli attack on Gaza. So we again hear these kind of recitations of the idiom that the virus knows no borders, and the medical community in Israel worried that a poliovirus might be transferred through Israeli soldiers to the Israeli society, and that is something that is of course important when we think about public health, but it also reflects what's on their mind of the Israeli medical community for almost a year now, totally neglecting to uphold very basic medical ethics in supporting their colleagues in the Gaza healthcare system, the West Bank medical professionals who are also under attack. with medical professionals in Israel explicitly calling for an attack on hospitals in Gaza. So I think we need to see that this kind of reactions by the Israeli medical community as something that reflects broader attitudes toward the life of Gaza and the life of Palestinians. We know that, of course, poliovirus is something that really terrifies a lot of us because it damages children, right? But then children are a major issue of this attack on Gaza, with 15,000 children dying, at least the same number of injured children, and just a cruel neglect of children's lives by the Israeli government. Maybe one last example for that is medical evacuations from Gaza for children and people who need immediate care for chronic diseases and for injuries has halted almost totally since May, when Israel took control over the Rafah crossing, with only 400 people leaving Gaza to get medical treatment. An estimation of 25,000 people are waiting to leave Gaza for very crucial medical treatment. And when the Rafah crossing was open, actually, the permit regime that Israel kind of approved for people to leave Gaza for medical attention, we see that only 57% of children between the ages of 0 and 5 were permitted to leave the Gaza Strip. I'm sure no one really think that a child at the age of between 0 to 5 can pose any security risk to Israel, but still almost half of them were denied permit. And like I said, since May, none of them really are allowed out for medical treatment. So we need to see that also as a reflection of the attack on children, the attack on children's life and health in Gaza as part of this attack. Thank you.
Thank you. Thank you very much for, I think it was an appropriate way to round up the presentations of the panel that began with talking about a virus and ended with talking about the current situation in Gaza that is really entirely determined at this moment by the Israeli military actions in Gaza and the state of war. So we have till 12:30. So I'm going to take the moderator's prerogative and ask some questions, and maybe the panelists want to ask each other some questions as well, which would be welcome. When I first sort of heard about the child who was paralyzed, and we all saw a video of this little infant under 1 year old, I started reaching out to people to try and understand what was going on in terms of polio in Gaza, and people pointed out to me that that was sort of the least of the problems of children facing, the destruction of sort of any semblance of normal life in Gaza now. But I think all of us can agree that children should not in this time face the risk of contracting polio. And as has been pointed out, Gaza had an astoundingly high vaccine coverage of over 99%. When I was looking at polio in New York State, we came across communities that had 25% vaccine coverage among 2-year-olds. It's a tribute both to the Ministry of Health and to the population, which cooperated with achieving vaccinations. Now, I'm going to take advantage of the panel, and you should just tell me if this isn't something you can answer. One thing that gave me some sense of that things might not be truly catastrophic, because I think we can argue that there is both the problem of exposure with the destruction of sewage management, raw sewage being a presence in everyday life, and the destruction of the healthcare system, meaning that children weren't getting vaccinated. That's sort of a perfect storm. But before the war, The vaccine, I understand, that was in use both in Gaza, the West Bank, and in Israel, is the inactivated polio vaccine, which protects against all three polio types. This will be too technical for maybe for many of the people watching. But I don't know whether any of you know what this to be accurate. IPV is protective against all three types. As you all know, the type 2 was taken out of the oral vaccine in 2016. But I think that all children who've been vaccinated in Gaza and in Israel, where they have had vaccine-derived poliovirus causing paralysis, that the children have been protected against all three polio types. So that the real risk is in infants who haven't been vaccinated at all, the biggest risk. Does anybody want to comment on that? This is for my benefit, and I hope of interest to some people watching. Is that Amir? Please unmute yourselves. You can all unmute yourselves if you like. In other words, yeah, go ahead.
No. Thank you for that comment. I would be curious from both Sam and Guy if they know this as well. I have colleagues in Palestine who said that the bivalent form was used in some centers, which wouldn't be too unusual. Many low and middle income countries still use the bivalent form. And so just to take a step back, in 2016, in response to these outbreaks or occurrences of the vaccine-derived polio virus from serotype 2, almost basically every country in the world switched in a couple of weeks' time to this bivalent form, which protects against serotype 1 and 3. And so, as you're saying, Dr. Bassett, it's absolutely true. Someone who's immunized with that would not actually be protected against serotype 2. But my understanding was that the inactivated polio vaccine was not used universally in Palestine. And so maybe Sam and Guy might know about that a little bit better.
That was what I was told, but that would be heartening, right? And because it would mean that this really is an effort to contain the circulation of this virus, but that most older children are protected. Let me just ask the question, perhaps to Sam. I mean, obviously, polio is not the only vaccine-preventable disease. There are many others which presumably children are also not being protected against. Measles can kill, particularly when malnutrition is a looming threat.
Yeah, absolutely. And look, in terms of the first question, maybe I'll best leaving this to the medical experts. My understanding was it was just a decision was taken about 10 years ago to switch to that bivalent or bivariant form, meaning that people under 10 were just not vaccinated against this type 2 variant. But it is something that I've not been able to get a clear answer to from colleagues. It does seem to be a subject of some debate, so maybe something to look into. And yeah, I mean, Mary, look, our vaccination programs are continuing. I believe we're in 2023 at UNRWA clinics, and UNRWA was by far the largest vaccinator of children in Gaza because 2/3 of the population are refugees, and they use our health services, and those health services are free, and they've persisted at a time when national services have been degraded because of lack of funding and isolation. So I understand that our vaccination rates in 2023 was somewhere between 70 and 80% for the year as a whole. Now, of course, a lot of the year preceded the 7th of October. We're continuing. We've got about 100 health points and health clinics that are operating in Gaza. We're continuing to provide those the EPI program of vaccines. And interestingly, look, for the second round of the polio campaign that will start in a few weeks, the health experts have looked at, well, is this an opportunity to vaccinate children against other other conditions, and measles indeed was something that was looked into, but it was felt that given the scale of a campaign such as this, the need to reach 600,000 children in under 2 weeks, that administering a campaign that needed needles and injections would be too complicated. So a decision was taken that there will be additional nutrients provided, but the focus will be on vitamin A. And this was a medical determination that given the kind of realm of conditions that children are exposed to in Gaza, this would be the most effective use of time, and it can be administered by drops as well. But like you implied, it does leave children prey to other infectious diseases that they've not been vaccinated against. Back to you.
Dr. Bassett, I think you're muted.
I think by now I would know to unmute. Thank you. It seems that one of the themes coming out from the panel is that the entire situation in Gaza is a threat to health, and that it should not be reduced to a single threat from one type of virus. Do any of you want to just comment on that? And I would be interested in particular to hear what you think the role of the medical profession should be in calling for the protection of Gaza's children. So anybody is welcome to go first on this. This is for all of you.
Perhaps I can make a comment and then maybe turn it over to Guy, who I think spoke very powerfully about the medical response in Israel. It's actually a very tragic scenario. All of this energy and funding and resources and really, as you said, heroic efforts going into implementation of the polio vaccination effort can all be undone with escalation or continuation of the war. I mean, it's very sad to think about it, but some of these children who are being vaccinated against polio may develop acute hepatitis A in a few months, may develop life-threatening diarrheal illnesses, or may just be found under rubble. And so the solution is addressing the political determinants of the war. In infectious diseases, we have this concept called syndemic theory, that when people have compounding social and structural obstacles to their health, that they actually have a synergistic effect. And that happens at the level of war as well, compounding this entrapped population who is subjected to airstrikes, dismantling of their healthcare system, attacks on their healthcare workers, restriction of aid coming in, and then even restriction of the vaccination campaign, as Sam described. And so it is really scary, and I'm particularly scared about hepatitis A, which also transmits through an oral fecal route, also at risk of spreading through sewage. Reports of more than 100,000 cases of acute jaundice, which is most likely attributable to hepatitis A, and could be deadly depending on the immune status of the person who's getting it. And then I'd like to turn it over to Guy, but I'll just say that what he described about the perhaps moral failing of many in the physician, in the medical, and the public health community, I think extends also here to the United States, to North America, where this issue, and specifically the health of Palestinians, has not really been open in our usual pedagogical spaces, in our usual professional societies, where we've either as a community engaged in self-censorship or have really not addressed this the way we've addressed other really urgent and infectious disease and other public health threats.
Yeah, so maybe I'll continue from Dr. Moharib's comment, and saying that I hope among our viewers, a lot of health professionals, saying that you have a lot of power. I mean, sometimes health professionals think that they have a lot of influence on their patients or on their close communities who they care for. But the Israeli healthcare community is very susceptible for international pressure. These are doctors that travel all over the world, participate in conferences, go on fellowships. And this is one kind of leverage that the international professional community can have some influence on Israeli society. And as in every society, the Israeli medical society is a privileged, strong. It has associations that kind of unite them together. So if they want, they can act. They can apply pressure on the Israeli government. And we saw that in other cases. For example, when there was an Israeli doctor who was arrested and attacked by police officers during a demonstration in Tel Aviv, immediately the Israeli Medical Association and other medical groups immediately were very clear about this has crossed the line, and we support our colleagues in their right to demonstrate or their right to attend to patients while demonstrating. So they can, if they want, to do and apply pressure. And we see here also with the polio virus, where the government listens, the Ministry of Health listens to these public health professionals saying that this also poses a risk to Israeli children. This also may cause the poliovirus to cross these borders and damage the Israeli citizens. So I think there are different ways in which we can work within our community, within the medical community, to try to stop this war, try to apply as much power, as much force as we can on the Israeli government to stop.
Thank you. Sam, you haven't unmuted. Did you want to add anything in here?
Just to agree, well, I agree with Guy as well, but I wanted to pick up on what Amir said in terms of the risk of infectious diseases. I mean, look, you don't meet anyone in Gaza right now who's not sick to some degree, be that, privileged international staff such as myself and my colleagues, everyone gets sick, but down to everyone on the ground. So indeed, a lot of focus on this, but it will be something else, like I said, next week, and that it creates an element of cynicism amongst some people in Gaza, wondering why this and why not everything else, and does this make people feel morally a bit more accepting of what's going on, feeling that they're doing something when the overall kind of callousness of this continues. But there was something, Mary, you said that also triggered something in my mind and around him. I mean, we've seen throughout conflicts in Gaza over the past decades statements about bombing Gaza back to the Middle Ages or reducing its development by decades. And essentially, I think you're seeing that now being played out in the diseases and the morbidity, aside from people dying of conflict. But these Gaza had the health determinants essentially of a middle-income country until the 7th of October. Infectious diseases had largely been eradicated. People were, affected by heart disease, diabetes, etc. And now this kind of reemergence of polio and other diseases which will come is really quite symbolic of the level and the extent of destruction that continues and will continue until this ends. Over.
First time that I heard any Israeli physicians call for ceasefire was related to the case of polio in Gaza, where several spoke on U.S. media outlets about the ultimate solution being a ceasefire. I wonder, though, whether we can also just talk about the fact that this polio effort is just an emergency effort to end the circulation of this virus and does not address even routine immunization as a right of children. And I wonder, this is really directed at you, Guy, whether maybe the polio experience at least opens the door to members of the Israeli medical profession talking about the restoration of and guarantee of some services to children, because I think everyone agrees that no political conflicts find their solution in harming children.
This is something we're still hoping for. I can give you an example. Like I said, the medical community in Israel was very silent about any of the results of the Israeli attack on Gazan healthcare system and the people of Gaza. But then there was a moment when the Israeli government wanted to deport patients hospitalized in hospitals in Israel and in East Jerusalem. They were evacuated from Gaza before October 7, and they got treatment in these hospitals. And then Israel, at some point in time, I don't even remember, I think maybe February, decided to deport them back to Gaza. And then we saw some doctors really who stood up for their patients and said, you're not going to take our patient. We talked to doctors in the hospitals and they said, you go, you appeal to the high court, you try to stop this, but we are going to stop them from taking them from our departments. We're going to stop. They physically stood and didn't allow them to board a taxi to take them to the crossing. And I think this is very telling, because when they saw the patient, the person they just treated, the children they just gave care for, and they related to them and their families, it was impossible even for them to imagine sending them back to Gaza. But this kind of abstract idea of thousands and thousands of millions, really, of children in Gaza is something that is, I think it's a leap of kind of, that we still hope for that leap to happen, right? For the moral kind of idea of we care for them, we care for, like James Baldwin said, all the children are ours. This idea that I think maybe these kind of cracks, like the poliovirus, maybe like these kids who were hospitalized in hospitals in Israel, maybe will allow us to open some hearts for change, and we still work for that.
Thank you. I think I should begin asking some of the questions that have come in. I want to thank you, Sam, for noting that the disease profile of Gaza has now shifted to that of an underdeveloped country with malnutrition, infectious disease, to overtaking non-communicable chronic diseases. So let me ask first whether this is a very specific question, I think, directed to you, Amir. There's a risk of a cholera outbreak in Gaza as well. And if you could just answer that.
Yes, absolutely. You know, I mean, like we've said several times so far, the environment is ripe for the spread of any of these infections of public health importance. And so, you know, the more that people are susceptible, the more that the environment and the kind of structural determinants are there, the higher likelihood that any introduction of an infection will result in a large outbreak. We can think of a few notable cholera outbreaks in the past. Haiti, after the earthquake, was an environment that was really susceptible to a cholera outbreak, and sure enough, it was introduced and it took hold. Yemen was a little different because Yemen had reports of cholera prior to the war, but of course, with that kind of relentless bombardment, aerial bombardment, and destruction of their healthcare facilities in the war since 2015, resulted in what is the largest reported cholera outbreak and was more accentuated in those areas that were susceptible to bombing. And so the same is true of Gaza. It would only take an introduction of cholera there. And the real question is there cholera there already? It would require testing diarrheal cases for cholera. In humanitarian crises, these testing reagents don't exist. The testing is rarely done. What happens is people are diagnosed clinically and managed clinically based on their symptoms. In polio, like you all mentioned, wastewater testing predated the testing of that patient. But I wonder if it wasn't detected in the wastewater ahead of time, if that testing didn't happen, this probably just would have been delayed by many, many months or years, the kind of recognition that there were cases of flaccid paralysis, which are really the tip of the iceberg. So to answer, I think the environment is susceptible. It would just take an introduction.
So on Haiti, for example. There was a question, and it's quite a long question, so I'm going to try and summarize it. is just about who has authority over Gaza at this moment. Gaza, unlike East Jerusalem and the West Bank, was has not been seen by UN agencies as an occupied territory. Yet all of these negotiations about immunization efforts to avert further spread of polio have been with Israel. Has it been with the Israeli military, the Israeli Ministry of Health? Who exactly does UNRWA and other UN agencies, UNICEF, and so on, negotiate with? That's for you, Sam. If I have, you know,
Yeah, no, look, there is a structure that's in place. I mean, there's a coordination body that's in place within the Ministry of Defense called COGAT, the coordinator, and I can't remember exactly what it's for government activities, coordinator of government activities in the territories, and they are essentially the interlocutor between the international community and the IDF. I mean, the UN and NGOs only have direct contacts with the IDF really when they're on the ground and they're dealing with battalions at checkpoints, etc. The more kind of tactical operational coordination happens through this interlocutor. There's a couple of them. There's COGAT and there's also the civil CLA it stands for. I can't remember exactly what it stands for right now, but these are the interlocutors, and they create all sorts of challenges in a sense that we don't have the direct ability to interact oftentimes with the Israeli army, but through this interlocutor. So they're not necessarily always the ones passing on or making the decisions. They're oftentimes more of just an interlocutor, but we are in touch with them. Thanks for putting that in the chat. Coordination and liaison administration. I mean, we are in touch with them several times a day. The negotiations and discussions around the polio campaign took place on a daily basis. And I have to say, at the kind of operational level with COGAT and CLA, those discussions were quite constructive in a sense that there was an understanding of the realities that we face, but they're also quite difficult. And it meant that if these calls were going on 10 o'clock at night, it was positive in the sense that there were those channels of communication. It just meant that after that, we all had to go back to the drawing board and redesign our plans based on what had been agreed or what had been put forward for agreement that was then approved or not several hours later when the decision makers themselves got involved. So the discussions with the UN at that level, and then at the political level, they're taking place with, between member states and the Ministry of Foreign Affairs, the Ministry of Defense, and the Prime Minister's office, I guess. Over.
Thank you. The Ministry of Health did not appear on the list of entities, even though this was a health crisis, at least. Is that correct? You had no direct contact.
We didn't, but WHO, the World Health Organization, were the ones most. I mean, they're the technical lead on all of this. The UNRWA role was more in terms of administering the vaccines on the ground, so much more of an operational role. I would expect that there were discussions between WHO and the Israeli Ministry of Health, but I'm not party to any of that, so can't confirm. Over.
And there's been another question about the general background role of malnutrition, which, as I understand it, there's been a blockade on Gaza for many years, but that it intensified after October 7th and greatly limited products coming and movement of people and things across the border. And there's growing alarm about the prospect of widespread acute malnutrition. What impact would this have on communicable diseases? It's the question. Is there a chance that these children will be immunized, but not effectively? something that has happened with the novel oral polio vaccine that's in use in Gaza, in Afghanistan, for example, where children were reported to have been multiply immunized and yet were still susceptible to infection.
If I could just say a quick word on that,
Yeah.
that's absolutely a concern in my opinion. Malnutrition can impact the susceptibility to infections, but can also impact the response to a vaccine. It can do that in two ways. It can reduce the immunity, or it can shorten the duration of immunity. And there has been many studies that have shown that malnourished children around the world require more doses of the polio vaccine to achieve population level immunity. There's also some studies that suggest that children who have a high burden of gastrointestinal infections respond more poorly to the polio vaccine, which could be present here as well.
Okay, that makes all the more important, I would think, that the second round of immunization go forward. Sam, can you just tell us a little bit about what the current plans are, and perhaps these could, taking a position of trying to ensure that these timetables are met would be important for the international community.
Yeah, I mean, absolutely. I mean, as I said in my earlier intervention, we have every reason to believe that the campaign will go ahead. It has been agreed. I mean, there were enough vaccines entered last time around to cover everyone in the first round. There will be a slight adjustment, I believe, of the target population based on this technical review that took place after the first round of the campaign. But for that campaign, the second round to be successful, we do need, everything that worked and was allowed in the first round to be allowed in. Again, that means prompt and timely entry of vaccines, cold chains, the ink to mark the kids' fingers, etc. Fuel needs to be brought in to allow us to move the vaccine around. Telecommunications need to work properly so that we can reach people, tell them what's happening, and there needs to be the pauses that were agreed during the last round, including the halt on evacuation orders, also need to take hold and be agreed. Again, it's very easy for this campaign not to be a success, and we shouldn't take it for granted. But all those things that happened in the first round need to happen again. But as I say, we have every reason to believe that there is a commitment to continue in a couple of weeks' time.
Good. I hope that can be followed by a campaign for restoration of at least routine immunization services. We're at about 15 minutes remaining. So I do want to offer the panelists a chance to just ask questions of each other or say anything that you haven't had a chance to say. As you are no doubt aware, Dr. Shalev, the U.S. organized medical profession has remained silent about this, about the impact on Gaza of the war. So I would be interested to know whether there has been any organized response from the Israeli medical profession. I know some 100 doctors called on for the ethical case for bombing hospitals, which are protected under international humanitarian law. Anyway, each of you, let me just give you a chance to make some remarks. All of the comments coming in the Q&A are thanking you for a very informative session. And I thank you as well. Let me go in reverse order of your initial presentations, and you please don't feel obligated to say anything if you don't want to. But Dr. Shalev, over to you from the Physicians for Human Rights of Israel.
Thank you. So maybe I'll also go in reverse order, and maybe the point of and end this atrocity. And I think, and I would want to hear what my colleagues have to say about that. And that is some sort of the rebuilding of Gazan healthcare system. And so we have been thinking about that with a few other international health-related organizations, thinking about what are the kind of the basic principles for rebuilding this system. And I think sometimes we think maybe it's too early to think about the day after, but I think the day after is something that is already now, especially concerning different policies that are already in the making of who will take kind of responsibility on Gaza, and looking at the healthcare system. I think this is very concerning. Dr. Muharrem mentioned Haiti, and thinking about how we prevent Gaza from becoming another kind of constant humanitarian crisis that is constantly managed by international organizations. And whether a very successful and heroic campaign to eradicate polio here now will also be used by different, definitely the US government, to kind of see that as the result. That is the kind of the recommended kind of policy for the day after we have all these very skilled international staff members and organizations that they can provide kind of the basic healthcare for Gazans. And we think this would be a disaster for the Gazan society as a society that has a lot of capacity within their reach, a lot of medical personnel, a lot of expertise. In spite of Israel's kind of limiting of any way for this society to develop, for many years, doctors and nurses and other health professionals were not able to leave the Gaza Strip for training, for fellowships. So this kind of de-development of the system is something that started many years before October 7. And I think we should all be very kind of conscious about what happens when the rebuilding starts, and what ways, what shapes it takes.
Thank you. Sam.
Yeah, no, maybe just reflects a bit on what Guy said, because I think it is an interesting point. And I agree with you. If we're not yet in the day after, we're somehow already in this kind of long day in between, when things will not be clear, when the areas of Gaza will kind of ebb into a bit of stability for a few weeks, and then they will fade back. But the overall context will remain one of conflicts and isolation and blockade. And look, I think one thing we have to draw from this polio campaign was, it was overseen and managed at the highest level by these international organizations, but the staff on the ground who were administering it were health professionals in Gaza, from the Ministry of Health and from UNRWA. I don't have the exact numbers in front of me of how many of those staff were from the ministry, but 1,200 from UNRWA, and most of the others will have been Palestinians. So I think, we've got this question of governance and who's going to be in charge, but we do have this highly capable, highly trained, highly professional workforce that, at least until the 7th of October and the university sector was demolished, was producing hundreds of trained medics every single year, many more than there were jobs for. And look, I think two things I see as risks. One is that many of these people will leave. Some will stay to rebuild the country, but others, given what they've gone through, will want to get out for the sake of their children, their children's future, their children's education, these kind of everyday activities that we can't blame them for in terms of life prospects. So there'll be a deficit in terms of human capital and human resources, and that will be more difficult to reconstruct and rebuild than the physical losses. And the other side of it, which we all know, is the trauma that people have gone through, and the health workers. I mean, heroic doesn't do justice to it, and some of them would shudder at the thought of being described as heroes because they're just doing their job. But look, there will be a reckoning at some point. What these people, particularly I think the frontline workers, many of them of whom are health workers, have had to put up with on a daily basis is for 11 months now. It's beyond what any human being can. It's beyond what any of us can really comprehend in terms of what it's going to do to people. So I think as well as the loss of human capital and the loss of physical infrastructure, it's what support is going to be there to help the health professionals who remain themselves to recover and contribute. And maybe, providing those services is the best thing that they can do. It provides structure, it provides direction to your day, but we shouldn't take any of it for granted. So how we as an international community and or Palestinians in the West Bank and in the diaspora and around and Arabs across the region can support that, I think will be one of the big questions that we'll need a good answer to in the aftermath of all this. Back to you.
Amir, and then I see that Jennifer Leaning raised her hand, and I do want to give her a chance to speak. I apologize if other people have been raising their hands. I've only been watching the chat. Amir, can I ask you to say a few things? And oh, we have more hands being raised. Well, oh goodness, I don't know whether you're able to speak. Could somebody in the group tell me? I don't know whether our technology allows people to speak from the so-called audience. Um,
Yeah.
let me just, Amir, let
Maybe
me
I can
ask
say a
your
few words
forbearance. Say a few words, and then I think Jennifer will, Dr. Leaning will be able to hear from, and then
Okay,
we'll
great.
try and wrap up.
No,
Thanks.
thank you. This is such a great session, and I'm honored to share the stage with the three of you. Just to reflect a little bit about something, the anecdote that Guy gave us earlier about when doctors in Israel had their individual patients threatened to be deported into Gaza and Palestine, they really spoke up vociferously, it sounds like, as I think we all would for someone who's in front of us. And I've been thinking about that since he said it, because I think it gets to what medical professionals, public health professionals see as the humanity of the person in front of them. And what has really tormented me over the past year is seeing other physicians and public health professionals fall into this trap of dehumanizing Palestinians, that if we saw them with their true humanity, we would be advocating for every child to be vaccinated, every child to have food and drink, and that can make us a little, being in this environment can sometimes make us cynical of the medical professional, but maybe we have to kind of come back and remind ourselves of how well we advocate when we see when we fight against the dehumanization. And perhaps the great inspiration for that is what Sam mentioned, which is just the heroic and sort of quotidian heroicism that is displayed by Palestinian healthcare workers and the Palestinian people, that when given the opportunity to be vaccinated, they surpassed expectations despite bombardments and restrictions from the Israeli military. And if that's what they can do with an oral polio vaccine, what can they do with soap and with other vaccines and with the antibiotics and with a functional healthcare system and education system, and ultimately an end to the occupation and apartheid and what the ICJ calls this plausible genocide. So that's what really leaves me, is the hope is that we can be inspired by them to see the humanity in the victims of this war.
Thank you. I don't know whether, let me try calling on Professor Leaning to speak.
Yes.
Okay.
Can you hear me?
Yes, we can.
Okay, great. I just would like to comment that this is a beautifully organized seminar that you, Mary, have put together, and the colleagues that have joined you, you are all extremely knowledgeable and measured and have given tremendously useful information that one does not find in even close reading of the U.S. and the British press, which is, I acknowledge, is limited in terms of its scope. But I think there are many people who want to speak out much more strongly, who I'm sure are on this webinar right now. And just to note that there are big constraints from organizations and from universities in speaking out on public platforms on this issue of Gaza and the war. So I credit those of you who have spoken out on this, who are situated in the United States. And I'm delighted that our UNRWA fellows, UNRWA leaders here have spoken out so well, but carefully, I notice, which is wise. And PHR Israel, I've worked with you in the past, and I am honored to meet you, Guy. I don't think I've met you before, but it's excellent to hear from you. And we actually, and this is what the FXB Center under Mary has been able to accomplish, we really need these conversations to take place in not a protected space, but one that is guarded by the content, by the guests who show up, by the moderators, so that there is a fair amount of truth that can be spoken to power. And so it is a real privilege to have listened to all three of you as guests. And Mary, my warmest thanks for your organizing this panel and for speaking out from your very considerable expertise. So I appreciate the chance to say thank you in this way. Thank you.
Thank you, Professor Leaning. For those of you who don't know, Professor Leaning was the director of the FXB Center for Health and Human Rights and is well known to your part of the world, has been active for many years in the Middle East. And so your words mean a lot to us here at FXB. We seek to match the courage of the people of Gaza and the health workers who have strived to look after them with our commitment to a more just world. All right, we still have 3 minutes remaining, but and we have other people who've raised their hands. Please accept my apologies that I was unaware that it was possible for me to call on people rather than just taking questions from the chat. Let me just end by saying how important it's been that all of you have participated. To thank you, Mr. Rose, for your service in Gaza, you, Dr. Shalev, for your words, your outspoken words. I can't imagine that you don't face some of the same constraints that we face in the United States, oddly. I've spent most of my working life in public service. I always thought that my move to the academy would be a chance always to be able to be outspoken. But we have had a very difficult period, as probably many of you are aware. And I am pleased also to have an outspoken physician and in our midst, in you, Dr. Mohareb. I really appreciated all of your comments. We have 2 minutes remaining. If there's any flash comments, October 12th, we're hoping to see the next round of the oral polio vaccine. I think we've concluded that we know that this is not enough and that we need more safety for the civilians of Gaza. Unfortunately, things don't seem to be headed in that direction, and nor are they for any of the people in your part of the world, Dr. Shalev. The risks of war just seem to be escalating all over the world. And of course, peace is a public health intervention that is extremely successful. All right. I have a minute for anybody who wants to say anything. My enduring thanks for all of you who have participated in today's webinar from all over the world. We thank you on behalf of FXB, the Palestine Program for Health and Human Rights. And I will then ask that we sign off.